Hello, welcome to another edition of Airway on Demand podcast interviews. I am your host, Dr. William Rosenblatt, Professor of Anesthesiology at Yale University School of Medicine. Our recording studios are at the Smilow Cancer Center at Yale New Haven Hospital. We're continuing our series of post-WAM interviews with Dr. Nasir, MD, who is the inventor of the eye gel. I got to sit down with Mohammed twice during the WAM meeting. You'll hear some change in the quality of the audio. The second recording had to take place in the only quiet place we could find, which was a stairwell. And we had a really fascinating discussion about his thoughts on the development of the eye gel during the 1990s. When did you graduate from residency training?
I graduated in 1986 as a doctor.
Okay.
Right.
Where?
In Pakistan.
Okay.
All right. And from there, I actually went into general surgery. So I wanted to be a general surgeon.
Okay.
So I trained.
Let me just say,
Right.
many of our airway equipment inventors.
Right.
Surgeons.
Right.
Yes.
So I started as a surgeon, and then my professor suggested it to me because there was shortage of anesthesiologists, and he said, wherever you practice, in a private sector in particular, you will have to anesthetize the patient by yourself as well. He suggested me that why don't you do 6 months of anesthetics so that when you are doing surgery, so you can properly monitor the patient as well with your assistant, because you might not get a qualified anesthetist. So that's how I entered into anesthetics, and here I am today.
So when you first were in anesthesia, you were using the classic laryngeal mask airway?
No, I started anesthetics in 87 in Pakistan,
Okay.
in Karachi. And I never had seen, or heard about laryngeal mask, because now I know they started the project in 1981, but it wasn't launched properly till 1989, kind of 88, 89
Right.
kind of a time. And I had never heard of it. And I remember quite clearly that my professor, where I started anesthetic, he would hate intubating because we used to have those red rubber tubes or black masks. And he would hate to the a point that he would make all of us residents, we were 17 of us, he would make all of us hold the black mask with a McGill circuit and say, no, you can't intubate. If you want to intubate, bring the sort of whole file of the patient to me, talk to me, discuss with me, prove to me that this patient needs intubating. And then I will come and stand with you and watch you intubating. And most of the people out of scare won't go to the professor, number one. And number two, he would actually, unless the patient is really full stomach or major surgery, everybody would avoid intubating. And so his point here was quite clearly that he would not call the word intubation. He would call tube placement. Because most of the time, and this is, I would emphasize to the residents who would be listening to this, that please, when you laryngoscope and see those two holes, don't get excited, please. Look at that, a beautiful landscape, a mysterious structures. Right? Just navigate around. Just see what you're looking at. Don't get excited. Your patient is not going to die, I can guarantee you, because if you have pre-oxygenated them properly, he is not going to die if you actually look at those structures for 5 to 10 seconds. Enjoy it, right? And then don't shove the tube in, right? Please, lubricate it properly. Place the tip of the tube, negotiate it against your glottis, and then just slowly advance it till it's placed up to a certain length. Don't just shove the damn thing in. It's extremely hard.
And even more crudely,
Yeah.
you don't, what you need in that one hole is oxygen and to remove CO2. You don't need a piece of plastic.
No, exactly. That's exactly what you're saying. And then that professor where I'm coming from, he would come and sniff around your neck and shoulders, and everybody would be scared to death because he was, something of the time. So on the third day of my anesthetic, right, what I had figured out, because my hands were absolutely gone every afternoon, and I would, sort of sit and think, why the hell, we have to put this tube into this hole, and why the hell we have to hold this mask? Is there not something anatomically designed which could actually sit on top, where you don't have to hold I can write my notes, as well as I don't have to, sort of cause myself so much trouble. And we can easily get away with providing the airway to the patient adequately. So I decided to speak to the professor. So I went to the professor's office, knocked on the door and said, "Professor, I want to talk to you," right? Thinking that professor has the authority to call the company and get the device made next month, and next day or next week. So I went to speak to him and I said, "Professor, I've got an idea." He said, what's the idea? I said, the tube we use and you hate it, right? And we hate it as well now. And the mask we put on the face, right? Can't we make a small mask on the face, it's made out of extremely soft material, so it doesn't actually hurt the perilarynx. It sits anatomically correctly on top of the larynx, right? Yeah. So why don't we do that? And hooray, we have got a new device. And he said, "Dr. Nasir, shut up and go and hold the mask." So that was the first concept ever came to my mind. Then I saw laryngeal mask in 1989. Then I saw, and as soon as I saw that, I thought, yes, exactly, I was talking to the professor. But okay, this is inflatable. I was talking something soft. But what changed my, sort of direction and dimension was the time when and the market hit with unique disposable laryngeal mask. What really, as I was saying yesterday, changed my ideology back to 1988 when I was talking to the professor was when the laryngeal mask company launched their disposable Unique. And that was the turning point that I used Unique on 2 patients. And both of them had a horrible sore throat.
Okay.
And one of them being a solicitor, an attorney. And the nurse rings me and says, "This guy cannot even speak. He is writing his notes and he is telling me that I want to see the doctor who actually put me to sleep, right? And if he doesn't come and see me, I'm going to sue him." So I went there and I put shined the light into his mouth, and I see this big, sort of horribly red looking, sort of everything. And I thought, oh my God, what the hell is this, And I'm driving back home and thinking, maybe what I was talking to my professor then, holds true. Should I start doing something for the best of my patients? So I kickstarted that concept and started working on it. And then I had, cut the long story short, I had, at that time in United Kingdom, I had 3 houses, right? And I sold first of my house after finishing my all the savings, which gone into it. Then I sold my second house, and everybody was hating me at home. I sold nearly my third house, but my wife stopped me, but we just remortgaged it. Till that money finished as well. So much so that then I entered into an award which actually supports these kind of projects to the Ministry of Trade and Industry. And I won an award which was actually worth about £65,000, so which is about $100,000. So that went into this project as well before I actually spoke to Intersurgical. I spoke to actually 3 companies, and everyone wanted this product. And when I spoke to Intersurgical, they said to me, "Oh wow, at least you have done 85% of the work before coming to us. Yes, we can do the rest of the work, and let's get it into the market." So that's how it started.
What year is this, more or less?
2003. Wow, and interesting thing was that, to be honest, that nobody except myself, nobody believed. Everybody was hooked onto the inflatable concept. Everyone, starting from the face mask that had a small, sort of hook where you can actually inflate the cuff of the face mask, then endotracheal tubes, then supraglottic devices, urinary catheters, cardiac catheters, you name it, everything has got a cuff, right? And all the doctors, especially anesthesiologists, they cannot actually navigate their thinking around how can a non-inflatable device can work in this kind of scenario. And I was saying to them that I'm looking for a material which is as soft as my tongue. And if I can actually place that material around the perilarynx in an anatomically landscaped manner, this is not a rounded structure that down there. You put a rounded balloon and you just inflate it left, right, center. It does not go left, right. It just actually compresses the structures centrally and causes trauma, thus the postoperative complications. It could not be a physical trauma, it could be just a compression, distension trauma. And that trauma, in my view, is causing this problem, right? And if I can actually have the material which fills that gap, that space around the perilarynx, larynx, I mean, now I have done, with Richard Leviton, we have done about 120 cadavers, of simple insertions to, sort of cutting down the neck and, sort of looking how the device behaves physically. Now, I mean, now I know what I know, but more I learn, more I know that I don't know. I mean, this is that kind of a scenario. This is such a mysterious space. And I mean, you see the guidelines changing every, 4 or 5 years. You see the new things happening. Why? Because we don't understand this area so well. It's a mysterious area. And how can we just suppose that you put an inflatable device, no matter it's intraglottic or extraglottic, that's not a place for inflatable devices. You just need to plug that hole, no matter what that hole is, whether it's larynx, whether it's perilarynx, whether it's your trachea. It has to be a device which does not cause that distension or compression trauma.
So some would argue that it's a very distendable. The pharynx, hypopharynx is very distendable.
Yeah, but still there's no space to expand. It is distendable if you hold it in hand. If you take say for example, if you take that space outside the body, put it on a table and distend it, it will distend. I have no problem with that. But in a closed neck, it can only expand so much.
The argument for a cuff device is you have some ability to create the seal. Obviously, the iGel, not a cuff device, creates a marvelous seal, right? How does it do it?
That's exactly, I'm trying to say that I was looking for that material which matches and marries the softness of the tongue. Once actually is soft like tongue and is actually just meshed together, it will not let any air escape around it unless it's excessively inflated.
Can I tell you my theory?
Yes.
My theory is, again, it comes back to the material that you use.
Sure.
That material, that particular material, given a very thin layer of liquid, that is saliva, against the mucosa, forms basically a capillary seal.
Right.
And
means a suction seal.
A suction seal.
Suction seal. I can give you that, but we have no data to prove that.
Right.
We have no way of proving that. How I see it, because when in a clinical practice, if you remove the device at the end of the operation, no matter 1 hour, no matter 7 hours, you remove the device, right? It comes out absolutely, number 1, clean. Number 2, it comes out dry. You take 9 devices or 8 devices of inflatable type out of a patient, they come out with a corpus secretions or blood, right? But iGel, 9 out of 10, if not 10 out of 10, come out dry. So if there was a saliva,
why?
Saliva concept, right. Because it's just being physically not causing excessive pressure, stimulation to cause salivation when the patient is waking up. Because, patient is anesthetized, no stimulus, because the nerves are not reacting to it. But when the patient is waking up, you must have noted some of the patients actually take the device out by itself. Funny enough, one of the doctor, actually, Dr. Wimblank, from a senior lecturer from Bristol, he told me he was walking with this patient in taking him to recovery in a corridor. And the patient actually took the device out, looked at it, and looked left and right and put it back in and closed his eyes. And we were laughing. It was funny that how easy it is, that it goes back in as well. But the point I'm trying to make is if it was your theory right, that it causes that kind of a suction, seal as well, it could well be. But, we hardly see any secretions on the device. So it seems like that the material now we have is 000. It's 3 times softer than your tongue. So it even embeds into your, sort of tissue anatomically so well that does not let the gas leak with that kind of a allowable, distensibility, if you like to call it. So that's why you get a greater seal. It's half the size of your other supraglottic devices.
What is the material?
Material is called SEBS. It's a styrene, ethylene, butadiene, styrene. It's a thermoplastic elastomer.
How did you find it?
How we found it was that this is the only material used in medical grade, manner, apart from silicon. Silicon or this material is medical grade soft material which can be used in the industry, but the silicon is about 4 to 5 times more expensive than SCBS.
When did this become available? This material?
It became available, but it was only available in the softness of up to 10. When I say 10, softness, sure hardness means your table or your wall is 100. Your tongue is 0. Right? So we had a softness of about 10. So no company would actually supply us at the softness of tongue I was looking for. So it took us about a year and a half to find a manufacturer. Now we have 3 manufacturers who are actually could get up to 0. Now actually we've got 3 manufacturers who can supply us at 000. So which is 3 times softer than your tongue. And it still retains the shape. While if you get the silicon to 0, it doesn't, and it will not retain its shape.
So here's another question for you.
Yes.
If it were 1985,
Right.
if this material had been available,
Yeah.
do you think Archie Brain would have used that material?
No.
Why?
I met Archie Brain on a lecture he was delivering in Paris. At the end of the lecture, somebody asked him the question, what do you think of iGel? And this is, I'm talking about 2008 or 2009, something like that. So somebody asked him, what do you think of iGel? He said, well, very politically correct. He said, well, number one, I haven't used the device, so I don't really know, how well it is. And number two, in fact, first, when I thought about the supraglottic device, I thought it as a non-inflatable device. I never thought it as an inflatable device. But then it occurred to me that a non-inflatable device is never going to work. So I dropped the idea and I went towards the inflatable. I said, well, fine, that sounds very politically correct, answer to me. So that's what I say, that he probably would have not chosen that route.
Another question, I think I know the way
Sure.
you're going to answer this, is there's this perception in the United States
Sure.
that the way the iGel works, I think maybe you know where I'm going, the way the iGel works is that when you place it into a patient, and my hope is that you'll dispel a myth here, that when you place it into the patient and it comes to body temperature, it remolds itself.
No, there have been a recent study as well where they have actually warmed the device and they didn't warm the device and it made no difference. It's thermoplastic elastomer. It does not change at the body temperature. It will only melt or mold at the temperature of about 120 degrees. Unless you really boil the patient up and be ready for the meal, it's not going to make a difference, no difference at all. What I actually normally say answer to this question is, unless you are measuring the base on the patient, you do not know the depth of anesthesia of that particular patient. And most of the patient, as we know, when paralyze them and insert an iGel, you don't see that phenomena at all.
What phenomena?
Of being warm. A lot of people say because it warms, it gets better and works better. The seal improves.
It's really depth of anesthesia.
It's related to depth of anesthesia. It's a myth. Is a depth of anesthesia because our larynx in a spontaneously breathing patient is still quite tight and patient has not reached to the level of a surgical anesthesia. So that's the less seal. As soon as they deepen, they relax, the seal improves.
See, and this was a problem in the 90s with the laryngeal mask in the United States.
Exactly.
Is that clinicians in the United States did not want to use muscle relaxants.
Exactly.
And it's once they started using muscle relaxants, everything relaxed and it was
worked.
better. And
absolutely.
so forth.
Absolutely.
Well, Dr. Nasir, thank you for joining us at AODpi. And it's a pleasure talking to you here at the WAM meeting. And thank you for taking your time out and for dispelling that myth. Thank you.
Thank you. Really appreciate that.
That concludes this episode of Airway on Demand podcast interviews. I'm your host, William Rosenblatt, professor of anesthesiology and surgery at Yale University School of Medicine, and I thank you for joining us. I look forward to your comments, which you can submit either via the Airway on Demand website or through the Society for Airway Management website. And if you have suggestions for further podcasts, I'd be delighted to entertain those. I also hope to see you at upcoming meetings of the Society for Airway Management. The next meeting will be in Atlanta, Georgia, September 16th through 18th, 2016. And this meeting is being organized and chaired by our good friend, Felipe Urdaneta. Once again, this is your host, Dr. William Rosenblatt, signing off and wishing you smooth airways.